populations. I'm quite excited about it and really looking forward to hearing from our speakers. To begin with, I'd like to acknowledge that I'm hosting this webinar from the lands of the Gunn people. I'd like to acknowledge the traditional custodians on the various lands on which you'll work, and the Aboriginal and Torres Strait Islander people who are participating in this webinar. I'd like to pay my respects to elders past, present and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. So our first speaker today will be Billie. So Professor Billie Bonevski is a professor of public health and a behavioural scientist at Flinders University. And today she's going to be outlining some of her work, and in particular evidence-based strategies for recruiting and retaining research participants. Thanks, Billie.
I'm just going to try to share screen again. Okay. Can everybody see my screen? Yeah. Okay, great. Thank you very much. Thanks for the invitation to speak, Emma and Bonnie and the South Australian PoCoG group. I'm really pleased, and it's on a topic that's very close to my heart and something that I've been working on for a long time. Before I start, I would also like to acknowledge that I'm on Kaurna land, and Flinders University has campuses that go up and down the central corridor, and I'd like to acknowledge those lands that we are represented on. This is it always was and always will be Aboriginal and Torres Strait Islander country, and I would like to pay my respects to elders past, present and emerging. Today I'm going to provide a little bit of background about myself because I'm new to South Australia, and I thought the South Australian branch might be interested in understanding who I am and where I come from and what I do. Then I want to talk a little bit more about priority populations as I referred to the groups that we'll be talking about today, and how I define them and why inclusion and diversity is important in health and medical research. I'll go over a systematic review of the literature that my team conducted that helped us understand what the more evidence-based approaches to increase inclusion and participation are. And I'll finish off with a few of our key learnings from that experience. Okay, so as Emma indicated in the introduction, I'm a health behaviour scientist. I come from the University of Newcastle in New South Wales. As a health behaviour scientist, I'm interested in why people take on certain health behaviours and how we might be able to modify those health behaviours in order to encourage more of the healthy behaviours and less of the less healthy behaviours. I was at the University of Newcastle for about 20 years, pretty much my entire career. And as a postdoc, I in fact used to work with the Cancer Council New South Wales for a little while. And then after a year or so, transferred to the university and stayed with the Cancer Council funded research centre. So I have a long history of cancer related research, and one of the very first projects that I did as a postdoc was developing the supportive care needs survey and implementing it across all of New South Wales cancer treatment services. And that supportive care needs survey is now the basis for a lot of survivorship research that's conducted across Australia and internationally. I've come to Flinders University this year to take on the Head of Public Health role. A lot of my work certainly over the last 10 years has been in disease prevention and health behaviour change in order to avoid the major chronic diseases like cancer and cardiovascular disease and diabetes and respiratory diseases. I'm an interventionist and a trialist, so we run behavioural and clinical trials like randomised controlled trials and other alternatives, and do a lot of research in the lead up, a formative research with consumers into designing those interventions, pilot testing the interventions, and then the randomised controlled trials to evaluate whether or not they work. And I have a particular focus on priority populations since they are at greater risk of disease, and often health risk behaviours are more prevalent amongst certain priority populations. So just to give you an indication, this is a really busy screen, but just very quickly, these are some of the populations that we've worked with, including people who experience homelessness, Aboriginal and Torres Strait Islander people, this one's with TAFE students, people who are receiving care for mental health or drug and alcohol use disorders, as well as people who are often socioeconomically disadvantaged, perhaps low income, unemployed, and require the assistance of social service organisations. So a really broad experience across a range of populations. And the other characteristic of my work, and this links into the research that I'll present in a little while, is that it's very partnerships focused. I work with service delivery organisations, with NGOs, with peak bodies to ensure that our research is relevant, but it's also a fabulous way to ensure that any interventions that we develop is sustainable for the long term beyond the life of the research. And again, this is a snapshot of some of the organisations that we've worked with. I've already mentioned the Cancer Council of New South Wales, a long time, and as well as health departments and health services. And NGOs are a fabulous way to ensure that your research is relevant to those target groups. Okay, so moving on to the main part of the population, and I thought I would just start with a little bit of a definition of who I mean by priority populations, and they're often referred to using a number of terms like vulnerable, disadvantaged, marginalised, hidden or hard to reach. Going way back to 1990, there are definitions like people who are disadvantaged and disenfranchised, so homeless and transient, those with mental illness. The language here is a little bit different nowadays, but high school dropouts, criminal offenders, prostitutes, juvenile delinquents, gang members, runaways, and other street people. More recently, CIDOR's provided a little bit more of a broad sweep and simpler definition of hard to reach populations are difficult for researchers to access. And I like to flip this around. I feel that a lot of those terms and a lot of those definitions put the onus on the person to be reached. And I feel that it's actually our responsibility as researchers to be able to engage all sectors of society. And in many cases, people haven't had equal opportunity to participate or be included in health or medical research. So referring to them as hard to reach is a little bit unfair. They may not be hard to reach. It's just that we haven't found ways to reach and engage them yet. And sometimes there are examples in the literature of people or groups being intentionally included. For example, many drug clinical trials have very strict exclusion criteria with things like psychiatric morbidity as a reason to exclude people, for example. So researchers have failed to find ways to reach and engage, and as a result, they're often not in our results, not adequately represented, and they should be our priority for trying to include them in research. And you may have heard of the inverse care law that says that those people who need healthcare the most tend to receive it the least. And this often happens in health research as well. So why is it important to include, to be as inclusive as possible in our research? And historically, if you look back at medical research, there has been an overrepresentation of white educated males in health and medical research. And what that means is that our research data and our results don't reflect the diversity of the entire population. And this poses a number of drawbacks. There's scientific drawbacks, like there's threats to external validity of our research findings and our ability to generalize our results to other groups and the entire population. But denying excluded groups involvement in research can also deny them the benefits of that involvement. And there is good data now showing that simply being a trial participant improves your health outcomes. So regardless of whether you're randomized or allocated to the treatment or control group, simply being part of the research process improves care received and health outcomes. If we don't include all, if we're not inclusive, then there's this inability to check the safety of new medical innovations with subgroups. So, for example, women metabolize drugs differently, and so only having males in our studies means that we haven't checked the safety of those drugs in women. And it also prevents us from understanding why differences exist. More recently, there's been increased focus on how cardiovascular disease affects women quite differently in terms of risk factors and incidence and outcomes than it does men. And when you look at cardiovascular disease trial history, you find that a lot of trials on cardiovascular disease historically have only included men. And that has now caused an inequity in cardiovascular disease between women and men, and we don't understand why that difference exists as well. So not being as inclusive as we can presents drawbacks, and being inclusive is that we can contribute to improving health inequities as well through our research. So we need to get better at including everyone, and it's easier said than done. And I acknowledge that. When I started working with priorities, it became increasingly clear that it is difficult to recruit particular subgroups of the population. And so my team conducted a systematic review of the literature of strategies. We thought we'd follow an evidence-based approach to using strategies that would boost recruitment rates, that would improve engagement in research, and that would maximize retention rates in research as well, amongst various groups. And our literature review had a fairly broad scope. It aimed to review articles regarding the barriers to sampling, recruitment, participation, and retention of members of priority groups in health research, and also review strategies for increasing the amount of health research conducted with priority groups. So the idea there was to understand why it's so difficult, what has stopped research from being more inclusive in the past, and how we might be able to overcome those barriers. The groups of interest for this literature review were those that were described as socially, culturally, or financially disadvantaged in some way compared to the majority of society. Okay. And after screening thousands of articles, we included 116 studies, and this graph shows the wide range of different priority population groups that are included in the review. Most or many were groups based on cultural, ethnic, racial background. And a big chunk of those were African American, because a lot of the studies were US-based studies. But then there were also other groups of people with drug and alcohol or substance use disorders, people who were just generally described as disadvantaged, Indigenous populations across various countries, people described as living with poverty, people living with HIV, people in rural, remote areas and with low income, and so on. And the types of studies that we found in terms of the study designs varied, unsurprisingly, because we did look at both barriers and strategies for improvement. So there were 9 randomized controlled trials, and they were trials of strategies for increasing inclusion and participation, and also non-RCTs. And then there was a lot of qualitative and descriptive studies, some case studies describing how certain research projects might have overcome barriers to, say, recruitment or high dropout rates. And we categorize the results of evidence-based strategies according to these 5 domains that align with the review aims. So firstly, developing a sampling frame to ensure it was as representative as possible, how to conduct recruitment and inform consent to try to increase recruitment rates, how to ensure appropriate data collection and measurement to be inclusive, which is particularly important for linguistically diverse populations, for example. How to boost intervention engagement and fidelity with the intervention procedures, and how to retain people in a research study longer term. And just due to time constraints, I didn't want to take the full hour today. I'll focus going over the results of these 3 components here, because they're challenges that most of us face in our research of boosting recruitment, maximizing intervention engagement, and boosting retention as well. So in going through these results, I'll run through what the literature described as the main barriers to priority group involvement in research, and then the strategies that that was supported by the literature. We did try to draw as much as possible from the higher quality studies for recommending strategies. But some of these, be mindful that some of these based on case studies, for example. So firstly, boosting recruitment and gaining consent. And there were 58 studies and 20 literature reviews based on that area alone. It was probably the most dense in terms of the amount of evidence that's available in this. Barriers that were reported and therefore not wanting to participate due to a history of being misused, not ethically involved in the research. And the strategies that were recommended for addressing that type of barrier is research that is genuinely community driven and that has strong community partnerships. Similarly, fear of authority, for example, preference for community-based research, or preference for people who are more local rather than researchers coming from somewhere unknown. And peer or known recruiters were recommended by the evidence base for overcoming that barrier. There was reports of some groups or some individuals perceiving harms from participating in the research. And again, there are really good examples historically of unethical research that did harm entire groups or individuals. And so there were a lot of studies that described how sensitive wording and using words like study, conversation, and dialogue instead of research, for example, or investigation or interview helps with. So getting that wording right was important. Similarly, mistreatment and exploitation concerns, and having a very personalized approach to recruitment. So using handwritten envelopes, one study found improved their recruitment rates compared to printed up envelopes, and enlisting the support of community leaders to break down that mistrust that might exist. And also the perceptions that there's no benefits to participating in research, that researchers are often FIFO, that we'd fly in and fly out. We go into a community or a group and we do our research, we get what we need out of it, and then we leave. And there was plenty of literature around how we can turn that around and provide very direct benefits to participants, like gifts and incentives and reimbursements, right through to more involved strategies like ensuring that our interventions or our research is sustainable long term, that even after we leave, that there is some benefit there for communities, ensuring that we provide project feedback, that we provide notes and gestures of gratitude for their participation and involvement, and improving communication, emphasizing the benefits of just simply being involved in research would improve that as well. In some groups, there are concerns around low literacy levels and difficulty understanding the language. And this could be either the country of origin language or health literacy as well. So strategies around using the appropriate media and having public information sessions where you can provide information verbally, having very simplified information and consent forms, and if possible using bi or multilingual recruiters. There's some cultures where there's cultural beliefs that might hinder participation in research, like gender roles in some cultures, and age, so older males might be harder to engage in conversations about health. And some of the strategies include cultural competency training of the research staff so that they understand those cultural barriers, having culturally targeted media, and tailoring your research to the local conditions. Sometimes some studies found that there are gatekeepers to your end target group. So often this might happen if you're recruiting through health services or general practices, for example. And so it's important to work with those gatekeepers. I know in one of my studies with recruitment through general practices, I used to deliver cakes to the reception staff in those general practices to ensure that that they liked us and we had a really good positive relationship, and we worked together. Recruiting locals as staff is really important, and having these sorts of financial incentives so that the health service and those gatekeepers might be able to see benefit in participating. And then finally, for this area, stigma and fear of being exposed. And so examples of that are for LGBTQI communities, for example, or drug and alcohol use communities where they don't want to be exposed as being members of those groups. So having more discrete recruitment strategies and ensuring that you have an advisory group that is providing very community-specific advice as to how to approach those groups. And online recruitment was an area that came through strongly as having been used to overcome that. And then there was a bunch of articles that just reported low response rates in general, and didn't really provide reasons for why those low response rates existed, but they did try to find solutions. And there was a host of strategies like ensuring that you have multiple contact attempts, toll-free numbers so that people can call you, having a settings-based approach, which I use a lot in my research. We work with mental health services or drug and alcohol services or homelessness services. Having outreach and home, and using texting to reach people, ensuring that you can provide transport assistance if people have to come in to you for any assessments or tests, ensuring that surveys are briefer, and creating participant registries. So there's a lot of strategies that I just went through for that particular area. The next area, and there's only one slide to this, is intervention engagement. And you know, often we go into communities or certain target groups that we want to work with, all gung-ho and so optimistic that, you know, we feel that our particular intervention, it might be like in my circumstance, a public health intervention, or we think it's going to do so much good, but then the community just doesn't engage, or, you know, individuals that you're allocating to receive that intervention interested and might drop off over time. So looking at ways that we might be able to improve that engagement, it was useful to understand what some of those barriers are. And in some cases, there were reports about concerns about randomization and it being unethical. I don't want to be in the control group, or if I go into this study and health program, can my family get it as well? And so randomization itself can cause, you know, quite a few concerns. And some of the strategies that were reported to help with that included having a control group where people got something, so at least a minimal intervention of some sort. There are also increasingly used alternative study designs to randomized control trials that can be quite robust, like waitlist, where the control group does get the intervention a later time. And one that I'm increasingly using more is a step wedge design, where the intervention is introduced to different groups in a staged way, so at different times. Education's really important, and ensuring that that you're explaining why randomization might be important, understanding using very simple terms how it decreased biases and what it means in terms of having greater confidence in the results. Then that, you know, often turns people around, because they didn't understand why, you know, they couldn't be in the intervention group, and now they do. And having trusted sources of information, of course. Sometimes the interventions that we develop are culturally inappropriate. So they might have worked with one particular group, and we want to test it with another group, and that is maybe inappropriate. So ensuring that there's community involvement in the development of that intervention, and there are methods that are described in the literature, like action research or cultural immersion. Cultural adaptation is another approach. Ensuring that your programs are culturally tailored has been described quite a bit, and having peers and locals involved in the delivery of that intervention helps this as well. I know that the next speaker is going to talk about rural health research, and distance certainly came up in this literature review about how do you keep people who are geographically just a long way away involved and engaged in your research. And there are some remote delivery intervention methods that were described in this evidence base. And then negative framing of your research or your research intervention might discourage involvement. So, for example, in a lot of what I do is, you know, telling people that they're overweight, or telling them that they drink too much, or telling them that their diet is poor and they're not exercising enough. All of that is very negatively framed, and people just disengage. And so turning that around and emphasizing the positives, and keeping track of progress and providing that positive feedback seems to help keep people engaged in your programs and interventions. And then finally, strategies to increase retention and attrition. Often in our research, we need to follow one-off survey, then, that might be easy. A one-off qualitative study, for example. But if you're doing longitudinal follow-ups, it's really important to try to minimize attrition as much as possible. And the three main barriers that came up in this area was researchers reporting just difficulty maintaining contact. So people or groups being highly mobile or changing their contact details, using what are they called, burner mobile phones, so getting rid of one phone and number and having another one, and so the strategy that was most recommended for addressing that is intensive tracking procedures with multiple contact details. So we tend to, when we're recruiting people into studies that have follow-up, we tend to take all of their contact details, including their Facebook group, their Facebook names, and any social media that they might have, as well as the contact details of their significant others, and ensuring that they have toll-free numbers as ways to contact us as well if they ever need us. Other practical barriers that people have that make it hard for them to attend or engage in follow-up include things like not having childcare, not having transport, taking leave from work if it's a very involved research project. And so I think it's very fair, and certainly the NHMRC encourage the use of reimbursements, and ethics committees now allow the use of reimbursement for people's time in order to try to counter some of these practical concerns. Having more of a participant-centered approach to research involvement, so being very flexible with how you follow up people. Some people you might be able to follow up with a telephone call, others text messages, others might need face-to-face, and so on. And also scheduling follow-up visits, if possible, if the study allows this, at their routine doctor's visit. So it's not an extra thing that they have to do. And finally, a lot of us forget. I forget, everybody forgets follow-up. And so using study logos on gifts, ensuring that toll-free number is on there, text messaging, sending letters, staying engaged with people, keeping in regular contact, and continually highlighting the benefits of that follow-up as well. So just a note on the methodological quality of this evidence base. There was, as I indicated earlier, a lot of variation, and that made synthesis challenging. And if you want more detail on any of these strategies or barriers, I'd suggest you have a read of the paper. It's quite a dense paper, but you might only be interested in a section of it. There were a number of randomized controlled trials that compared strategies, and they were very useful, but also the qualitative research was very useful for understanding those barriers. And even the case studies, although they're lower level evidence, they do provide some insights, some helpful advice as to how you might be able to approach a particular priority group or particular challenge in your research. But overwhelmingly, well-designed methodological research is needed to improve the quality of this evidence base. So more trials of recruitment strategies, for example. So finally, the main themes that came out of this is that there's multiple barriers And that requires multiple strategies. There's no one size fits all. It's not like I can say, well, just use financial incentives and that'll solve all your problems. That's not the case. There are examples where financial incentives might be culturally inappropriate for a certain group. So it is important to tailor. And you can't generalize from one priority population group to another as to what might work. Community engagement and partnerships came across really strongly in this literature review, and also incentives and reimbursement is a very practical measure that can be applied. Cultural appropriateness is very important, and having some level of flexibility in your methods and your approaches, and sustainability of the research that you are doing actually has benefits for that person or that community long term, and multiple strategies are needed across each of those 5 research process points. This has a lot of implications for us as researchers. It means a lot of time, costs, and data ownership implications. Time-wise, we need to view working with priority populations as a long-term project. We need to develop our research together with these priority populations. It means developing relationships and partnerships, and ensuring that our interventions are culturally appropriate and relevant to them. And then at the other end, providing feedback and maintaining that engagement to some level at least. And this affects project and publication timelines. There's cost implications. All of this is resource intensive. Having translators or multilingual interviewers or recruiters involved in your study, having flexible and variable data collection methods, incentives and reimbursement and so on, requires careful budgeting, and it affects your funding applications. But in my opinion, it's all perfectly justifiable, and so long as it's included in grants, and you can show that it will improve participation, and therefore the end results, the quality of your research, it's justifiable. And data ownership is an important consideration that affects authorship. It needs to be negotiated and collaborative. We're doing a lot more of this with Aboriginal and Torres Strait Islander communities. It is a partnership, and they should have equal authorship involvement and status, and this might slow down the publication pipeline as well, but it's all very worthwhile if it means that you're developing trusted partnerships, and more communities and people are involved in our research. We can actually do something about tackling health inequalities in that way. So take home messages, last slide, I promise. Greater representation of priority groups is likely to yield benefits for your research, but also for the community. And representativeness can be threatened at various stages of the research process. Always remain mindful of who you might be excluding, and employ strategies to try to avoid or at least minimize that exclusion. And as research, we are in a really powerful position to make a difference to health inequalities through our research. Thank you.
Sorry, just had to get myself off of mute there, but thank you so much, Billie, for that fantastic presentation. I think you've raised a lot of really interesting points, and there's a lot of helpful strategies there. I'm trying to get some surveys back at the moment, so I'll be possibly applying some of the strategies that you outlined. I'd like to move on now. We'll save questions for the panel discussion at the end. So I'd like to move on to ask Kate to present. Kate is a Senior Research Fellow in the Department of Rural Health at the University of South Australia. And her research interests include understanding and addressing the psychosocial needs of rural people affected by cancer. Thanks, Kate.
Thank you very much. Can you all see my presentation?
Yep.
Yeah, excellent. Yeah, well, thank you for that wonderful overview, Billie. I think, yeah, your systematic review is so useful and sets the scene really well. With my talk, I'm just going to speak briefly on working with rural people and sort of dive in a little bit deeper as an example of a vulnerable group that you might be interested in working with. So I am a clinical psychologist and I have experience working as a psychologist with people affected by cancer. But I also completed my PhD on the psychosocial needs of rural people affected by cancer about 8 years ago. And I've been researching their needs ever since. And I was also fortunate a couple of years ago to be awarded a Churchill Fellowship, which enabled me to travel all around the world and meet with clinicians and policymakers and other organisations who are also decades as much as I can. And what I guess this means is that I've witnessed firsthand some of the challenges that were because I've actually found sharing this little bit of background with my participants, basically letting them know that I'm from a rural background too, actually is something that can really help build rapport, because I found that a lot of rural people are quite suspicious of academics, and particularly those who live in the city and are FIFO academics, as Billie pointed out, they really don't like them. So I think if you can authentically share something about yourself that kind of puts them at ease and kind of aligns your interests with theirs, that can be a really useful strategy. But I wouldn't recommend, don't pretend you've got a connection if you haven't, because I'll see straight through that as well. Putting my personal motivations aside, improving outcomes for rural people affected by cancer is really important because a third of the population lives outside metropolitan centres, and this is places on the map that are coloured anything other than the darkest green. So if you fall into this category and you're diagnosed with cancer, your journey is likely to be very different to someone who's diagnosed with the same disease and lives in the city. And to paint a picture of this, I'm going to give you the example of, let's call him Bob, who's from Port Kenny, like me, and John from Prospect in Adelaide. So if we were to, if Bob and John were both the same age and were diagnosed with the same type of cancer, Bob would actually be 35% more likely to die within 5 years than John. So, of course, being diagnosed with cancer is tough for anyone. And if we were to interview someone like John about his experience, cancer treatment 7.5 hours away from his family and friends and support networks in an unfamiliar city. And he's self-employed, like a lot of people in rural Australia. He doesn't have sick leaves. He's worried about how his neighbour and his wife might manage his animals or his stock while he's away. And while he might be grateful for accommodation supplied by organisations like Cancer Council, he still finds this experience of having treatment really expensive, lonely, and stressful. And I think the quote sums this up when he says, on top of this, I've got to try and where am I going to stay? What accommodation? I can't drive the bloody car around. The traffic's too much for me in Adelaide. How am I going to get around? And I can't afford taxis. So they've got that extra layer of stress. Just to set the scene as well, to help you understand why I think it's important for us to do research on these vulnerable populations, in particular those in rural areas, is because in addition to having poorer treatment outcomes, rural people affected by cancer are also likely to have their cancer diagnosed at a later stage, possibly due to differences in access to screening services. But differences in survival have even been shown to exist after the cancer stage is controlled for. Rural cancer survivors are also likely to receive inferior treatment, minimizing home. And across the world, that's something that's found, that the further a person lives from a radiotherapy facility, less likely to receive therapy. Demographic, socioeconomic, and these factors are controlled for. There's also a high incidence of particularly nasty cancers in rural areas, so prostate, melanoma, cervical, lung, and unknown primary. And this is probably due to increased sun exposure and elevated rates of smoking. And rurality often coincides with low economic status, lower education, and there are more disadvantaged groups living in these areas. And in many parts of rural Australia, there's also a lack of GP. The cost of accessing care is very expensive, and there are attitudinal barriers to accessing health and support services in these areas, even when the services are physically available. In the US, there's also research that has shown that rural people with cancer are likely to have poorer mental health than those in the city, but we recently conducted a systematic review of this and looked at all of the research on the psychosocial needs of rural versus urban cancer patients that has been done in the last 10 years. And what we actually found was that while that might still be true for America, in Australia, we actually have seen improvements in rural people's mental health. And while they still certainly have unique psychosocial needs, there's not so much evidence that their mental health is worse than their urban counterparts. So what does all of this mean for doing research with rural people? So I guess the first message I wanted to convey to you is that it's really important, more people research to understand why differences in cancer outcomes exist between rural and urban populations, so that we can develop targeted ways to address them. And the second thing I really wanted you to take away is that if you're doing research in an urban setting, it's important to remember that for many of these people, just being in the city is a very overwhelming experience. So you need to be careful in the way that you go about conducting your research so that you don't make that worse. And I'd just like to encourage all of you to think about how bamboozled you might feel if you were dropped in the middle of, Beijing or New Delhi. And be aware that for some rural people, they may actually feel very similar when they have to come to an urban centre for cancer treatment. And I think this is probably true for a lot of the vulnerable groups that Billie highlighted earlier. So if you go and then approach them with an information sheet and a long questionnaire and ask them to do all sorts of things and speak really quickly, you might not get the response that you're hoping for, which I think is fair enough given the context of what they're having to manage. So a few years ago, I actually asked a group of rural people affected by cancer what they wished that urban-based health professionals knew about them to make their cancer experience easier. And I think there are many lessons from this for urban-based researchers as well. First thing they said was being away from family and friends and support networks during treatment makes it very stressful. And what I think this means for research is, that they may prioritise seeing their family and friends if they're visiting over your research. And I think we have to kind of accept that and respect that as well. Something else they pointed out is that staff in small rural hospitals know their names, and they find the anonymity of large urban hospitals really quite impersonal and a bit distressing and difficult to navigate. So if you can make sure that you use people's names, and this isn't just rural people, I think it's people in general, this is good practice, use their names, they will respond a lot more positively to you. Something else that really does help with rural people is if you acknowledge that they've travelled, and if you know where their rural town is, or they can show you on a map how far they've come, it will really put them at ease and make them far more, they'll warm to you far more quickly. So if you don't have any idea about rural places and you're recruiting in the city, take a map with you and ask them to show you on a map where they've come from, and make an effort to acknowledge the challenges that they've faced in getting to treatment and getting to a point where they can participate in your study. Something else that rural people find difficult is travel, and having appointments scheduled together and not changed at the last minute is really important. So when you're scheduling interviews or whatever it might be, you really need to be reliable, but you also need to be flexible to meet their needs. And remember that accessing treatment and minimising travel really must remain the priority, and you should do all that you can to make it as easy as possible for people to participate in your research. If you can, it's also good to use to allow people to have tests done closer to home, or maybe to have do interviews over the phone or via Zoom. And something else to be aware of is that many rural people find it difficult to ask for or to accept for help. So if, on our information sheets, we always put helplines and say that, if anyone becomes distressed, we'll encourage them to ring them. But I think you just need to be aware that these are pretty stoic, sort of tough people, and they say themselves that, just making a recommendation to a service, it probably will mean that we won't actually mean that we go and use it. So you might need to remind them a couple of times, and also kind of normalise the fact that, lots of people ring the Cancer Council helpline. It's perfectly fine to do. And, they answer questions like this every day. So minimising the stigma associated with accessing help is important. A couple of other tips. I would recommend, don't pretend you know where someone is from, like a country town or something, if you don't, because they'll see, or don't pretend anything. They'll see through it straight away. And once you've lost that trust, as I said at the beginning, and as Billie highlighted, the levels of trust in academics and researchers is already pretty low. So you can't afford to lose that in any way. Something else to keep in mind is that people pick up on if you're being condescending very quickly. And, although rural people's health literacy levels might be lower, you need to speak to them in a respectful, kind of careful way. And it was interesting when I was asked to give this talk, because I thought, oh, wow, I don't think that rural people would actually even like being called a vulnerable group. They're generally very proud of their rural identity. So, we need to remember that as well, and not kind of treat them as though they're an exotic species. And something else I think that is really important is, if you possibly can, conduct your research in their setting, in their rural setting. So go to them. And if you bother to do this, it will give you a lot of credibility. And I was interested that Billie mentioned the FIFO, don't be a FIFO researcher. It's absolutely true. If you can drive to the rural location and conduct your interviews in person, you'll win a lot more credibility than if you fly into town, because I think it just shows that that you're not afraid of travel and distance, and you understand them to a greater degree if you've had to travel in a car to get there. And the other thing I'd suggest, if you can, if you're interviewing on a Monday, go there on a Sunday and bother to sort of get to know the place in which these people live, and they'll really and take an interest in their community. They'll really appreciate it. They really don't like it when people blow in and blow out and then they never hear from you again. And writing personal thank you notes, which Billie also mentioned, is something that I always do, and people are, very, very appreciative of. So just in closing, I just kind of wanted to highlight that a lot of rural people kind of feel forgotten and neglected and also misunderstood by people in the city. And I think they also have the potential to feel threatened by people who are more educated than them. So, you know, when I go out and do research in rural areas, they're often really surprised that someone is trying to genuinely understand their needs and look out for their interests. And you know, if you work with this group, you'll often hear things like the bottom quote below, and that's someone said, the rules are made in the city and then they try and stamp them on you in the country, and they just don't work, and they make things worse and they make things harder. So I think it's important to explain that it's through doing this sort of research and giving rural people a voice and helping them to advocate for what they need and to ensure that their specific needs and preferences are met. It's by doing this through research that we can actually help these rural people address this issue, so that city people don't come in and stamp interventions on them that don't fit with their way of life. So I'll leave it at that, and yeah, happy to take questions at the end.
Thank you so much, Kate. That was an excellent presentation as well. And I really liked your example of, you know, how might one of us feel if we were just dropped in Beijing or something like that, as a parallel for how somebody coming from a rural area might feel if they were coming to an urban centre for treatment. Thank you very much. We'll move on then to hearing from Jess. So Jess is a qualitative social researcher in the Behavioural Research and Evaluation Unit at Cancer Council South Australia, or Cancer Council SA, and she currently facilitates the Culturally and Linguistically Diverse Communities Focus Group project. Thanks very much, Jess. I think you're still muted.
There we go. Thank you so much for inviting me, Emma, and thank you, Billie and Kate, for your lovely presentations. I think they all fit together quite nicely because I'm going to talk about a different area of research now, which is working with culturally and linguistically diverse communities. So similar to Kate, I guess I'm going to give a bit of a case study on a certain project, which will hopefully relate to some of the things presented already. So my background is in qualitative social research, and a lot of what I've done in the past has focused on health and values, sort of broadly, with a special interest in food and drink, which isn't necessarily relevant here, but just so you know where I'm coming from. And I have also had a sort of theoretical and methodological commitment to working with I guess, historically marginalized or vulnerable groups, and using methods that sort of help to amplify their voices and perspectives through my work. So this project I'm working on with Dr. Tony Daly, DM Tran, and Shala Rostami. I just wanted to acknowledge the work they do. And I think what's perhaps a little bit different about this as well is that I'm working in an organizational context within Cancer Council. And so some of what we're doing here is trying to move from, I guess, my background in doing work that is sort of in a more critical space to a more applied space where we're conducting research that can inform our service delivery as an organization, as well as our advocacy activities. So I'll just give you a little overview of this project. As a background, the reason we decided to do this project is because I guess there's a lot of unknowns about, I'll use the acronym CALD for culturally and linguistically diverse communities and cancer control in South Australia. In South Australia, we know that we have nearly a quarter of the population who was born overseas, and perhaps more importantly for this purpose, 17.4% speaking a language other than English at home. People like me who were born overseas but speak English quite well and come from a country with similar sort of healthcare system, might not be quite as disadvantaged in this area. We also know that about 1 in 5 South Australians affected by cancer come from CALD backgrounds, and significantly, people with CALD backgrounds are much less likely to participate in the nationally offered screening programs, the breast, bowel, and cervical cancer screening programs. We also know from our own data that our services are underutilized by CALD communities. We have a much fewer people from CALD communities calling up our 13 11 20 helpline, accessing counseling, etc. So coming from the knowledge that cancer screening and prevention activities overall reduce mortality and can improve outcomes, we see this as an equity issue in terms of improving not only our access to our services, but how we can increase things like screening and other sort of preventative health activities. The difficulty here is that we're talking about very diverse groups of people. So there's a broad body of literature that looks at cancer and other sort of health related behaviors and activities and identifies various barriers, cultural barriers, emotional barriers, structural, practical types of barriers to engaging in cancer control and support activities. What we also see in the existing literature is a huge variation in cancer screening, prevention, and support views and needs, both between different migrant communities and within these communities. So we might have quite a big variation between, say, a Chinese community who has been in South Australia for a long time and something like Congolese community, but we'll also see a difference within those communities that will really vary based on professional roles, education, the length of time in the country, the visa stream that they might have migrated on, et cetera. So there's a lot of factors to deal with and to think about in doing this research. So we decided to use what we could see from the literature and from South Australian demographics to develop 2 categories for this study, which we termed established and emerging communities, and to see if this is a useful framework for understanding cancer control priorities in different communities. So established communities we've defined as those that have obviously had a longer time that they have been a significant population in South Australia. And a lot of these communities are large percentage of the population who are over 50. And this is relevant for these purposes because this is when we start to get into the screening age for the national programs. Now we have emphasized Asian communities, this project, because these are seen as forming the next wave of aging populations. So Chinese, Vietnamese, Indian, for example. But we've excluded European-born Australians in this study because a lot of this population is aging out of screening and also have been quite highly studied up to this point. And for the purposes of this study as well, we've defined these emerging groups as those that have really grown exponentially in SA over the past decade. And we see in these groups quite often a large number of people coming to the country via the humanitarian visa stream. We often see that these communities are younger on average than the general population. So a lot of them aren't quite at screening age yet, but may have other concerns and other areas that aren't being met regarding sort of prevention and support in related to cancer, and often face English literacy, education, and employment challenges. And I would also say sometimes face even challenges in obtaining citizenship, so where permanent residency citizenship is still quite low. A lot of students or a lot of people still on temporary visas. So there's very little literature on these communities, and that's really a big gap that we're also looking to fill with this research. So because this is an area that is so unknown, but also because we're working with a lot of groups who we're not even sure what questions to ask them, what are their priorities and what are their perspectives, we felt that qualitative methods are really important in order to really hear their perspectives without overlaying our own our own ideas about what they need, or even what they might, what barriers they might face. So we decided to do a focus group study design, engaging with lay members of a selection of established and emerging communities. And this is somewhat based on the literature and somewhat based on sort of convenience around the communities that our organization has a relationship with. And I suppose that's also one of the sort of benefits of working in an organizational context, where one of our project team members is actually a called officer, and part of her job is maintaining these relationships. So we chose three groups for each category: Chinese, Vietnamese, and Filipino in the established, and Nepalese, Afghan/Syrian, kind of Middle Eastern broadly, and Congolese in the emerging areas. And we developed some semi-structured focus group questions, exploring key themes that we found from the literature, but also, I guess, keeping it loose enough that we can veer from that script where needed. And I think also importantly, we shared that with community leaders in advance to make sure that the questions were not culturally inappropriate for the groups that we're working with. So the key themes that we were broadly exploring were structural barriers to accessing health services. Those would be kind of quite pragmatic things, such as language, the ability to catch transportation to get to medical appointments, the cost of medical appointments, the waits in emergency, et cetera, things like that. Service-related barriers, we categorize those as those that are really a bit more abstract in terms of interacting with the health system in Australia, which can be quite jarring and quite different for people who are coming from a different kind of medical system. Cultural barriers, this is for our purposes about cancer, their views of cancer and understandings of cancer. And I guess that sort of fits more broadly into understandings of health and disease and beliefs in that area. Things like prognosis, survivorship, and also support has come out as a really important area, especially emotional support, and how people may or may not seek emotional support, the impact on the family and community, et cetera. And then finally, awareness of Cancer Council and how we can kind of work to establish trust and better community relations to better serve these populations. And our recruitment for these groups has been so far through our existing contacts and relationships with community leaders of various groups. And it has mostly been our called officer who's been in charge of doing that recruitment. So she initially would contact community leaders, and then they would do recruitment within those groups, finding people in their communities who wanted to participate. I should note we also offered an incentive in that we had three vouchers for each group, and we'd do a draw at the end, which was kind of a fun activity to end each session with. Some of the challenges that we faced, I mean, kind of the obvious one is that we've been trying to do group face-to-face research in the middle of a pandemic. And because of that, we've had to cancel several sessions due to really poorly timed lockdowns. That has been quite a bummer. And it has proven very hard sometimes to get a group to be willing to reschedule after a cancellation. I do wonder how much this also impacts on recruitment. People hear about us wanting to gather people together and do an activity. And there's been a lot of hesitance to participate. I do also suspect that we have encountered some barriers with some groups due to what they might perceive as a research burden on populations that already maybe feel over-researched, or that we're asking something of them, though we've tried to, within the Cancer Council organization, set this up so that they do feel that they're getting something out of it, so that we can be offering some kind of service. We have sometimes found, and I would say this is particularly true in what we've called the established communities, that may feel that they don't necessarily need that, or that they just already have enough going on. So we've conducted initial focus groups with Nepalese, Chinese, and broadly African participants. And when I say African, this was through the African Women's Federation of South Australia. So it was mainly people from the sort of Ghana and Ivory Coast part of Africa, but a few other countries as well. So that's what we've done so far. And I guess that makes us about halfway through our project, and we've kind of hit some barriers. So we've decided to kind of expand our recruitment methods so that we can reach, not only so that we can reach some other communities, but also because we have questions about how representative the participants are of the broader community. And of course, in qualitative research, we're not necessarily looking for representativeness, but I do wonder if we are missing some of the barriers faced by the most sort of vulnerable members of those groups, because looking at sort of the demographics of the people who have participated so far, we are often finding them to be slightly more educated than what we know about the demographics of the whole group overall. And so we feel that speaking, at least that we need to kind of try to fill those gaps and make sure that we are finding out about all the barriers that these groups might face. So we've expanded our methods, and our expanded methods are now out for ethics approval. But we decided to include some individual interviews in our methods so that we can take a focus group transcript, analyze it, look at our findings, kind of identify what we think are the key themes and the gaps, and then sort of bring that to community leaders and healthcare providers who work with some of these populations to try to see what we might have missed or what we might have gotten wrong from our analysis so far. So we're doing that through a mix of direct contact and snowballing, using some of our colleagues, for example, at SA Health, but also public contact details to try to just get a few more perspectives to bring into the research. And also to expand our focus group recruitment through our extended network again. We've also considered whether or not it's useful to use social media in this recruitment. It's not something we've really done with these kind of populations before, so I might just leave that as a question mark at the moment, and happy to hear other people's feedback later on. Just a quick overview of our initial findings so far. That as per the literature, we have found that there are differences not only between the communities, but within each community. We are not quite sure yet how useful this established and emerging framework is. It might have some utility, but there may be other metrics that are more useful for thinking about how we approach different communities and how we work with different communities. For example, the level of English literacy, care group, as opposed to our Nepalese group, who actually, despite being classified as well as an emerging group, the people in our session were actually quite familiar with evidence-based healthcare and quite adept at navigating the Australian healthcare system, whereas we saw more barriers for that among some members of the African community. But again, this was hugely variable because we had people in the group who were healthcare workers themselves, who had PhDs, as well as people who really didn't have that kind of education or who were newer migrants to the country. So huge variation even within the group. One very strong finding, and I think this is true across the board, and I've heard probably both of the other speakers today bring it up, is the importance of community organizations and those kind of structures that are already there. In the CoLG communities, these are actually very strong structures, and they're really valuable channels for cancer control and support engagement. So it's been useful for us in terms of research, but also in terms of how we can sort of deliver some of our services, even getting the message out that we're here, that we can offer services, as well as doing things like, running a screening session or engaging with GPs. Another strong finding that again seems to be quite true across the board, and I'm not sure this is entirely unique to CoLG communities, although there do seem to be some cultural beliefs in this area, is that there's really a need to increase community awareness of the emotional and mental health support services that we can provide. But it's really important, I think, to emphasize that for a lot of people that we've spoken to so far, it's not really seen as culturally appropriate to ask for emotional or mental health support, whether you're somebody diagnosed with cancer or a carer or family of that person. So I think it's important to keep us emphasis on privacy, so people do feel comfortable accessing that. We have seen a need to improve translated resources, this especially came out strongly in the Nepalese community. And a really, I guess, particularly for our African community members, there does seem to be a need for more outreach, education, and support for navigating the health system very generally, but also for health professionals. And a lot of this comes down to different communication styles. For example, a sort of more narrative or storytelling kind of communication style in a healthcare setting versus what health professionals are used to, a very sort of factual kind of shorter consultation. And it's interesting that even community members have developed ways to get around this. For example, one community leader said, well, I just tell people book a double appointment so you have more time to talk through what you need with your health professional. But I think health professionals certainly need some support and training around how to work with people who are coming from a culture where the medical system is very different, and the sort of understanding of preventative care, it just isn't really there. So there's a lot of work to do there. So our next steps for this project in particular are that we'll be conducting at least one more focus group. We really do need to have one more established group. We're working through contacts, trying to organize a session with a Filipino group. We do have a group scheduled with a Middle Eastern women's group, which is consisting of Iranian and Afghan women, and possibly a session in the Southeast with the Afghan community there. To recruit for interviews with health professionals and community leaders once we have ethics on that, to help clarify our remaining questions in that area. And again, further analysis and comparison to think about what frameworks are useful or whether there really is no useful framework, and what we can do with our findings in that area. I just wanted to offer as well a few reflections on my experience working with culturally and linguistically diverse populations on this project. I think, first of all, being part of a diverse research team is a plus. We all come from migrant backgrounds, actually, in our team, which is interesting and gives us some different varied perspectives. But also we have sort of different commitments, whether that's sort of more of a public health, a community outreach, or for me, you know, a research output kind of goals from the project, which helps us sort of bounce ideas off each other in a really useful way. The importance of consulting with community leaders in advance, I think, really can't be overstated here. Again, the use of the community organization network and the strengths that's really a strength of a lot of CoLG communities has been really useful. And again, I've said in advance when we're sort of designing it, but also at various stages of the research, checking in around our findings, around how we interpret our results as well, to bring some of the community back into that, make sure we are getting it right. I think there are benefits and drawbacks to recruiting via community organizations. I mean, largely benefits, because that's sort of, again, how we can distribute and disseminate information and about our services as well. But the drawback, of course, is we have a bit less control over who ends up participating in the research and you know, how representative that is. And I think there's still that problem that, and thinking about what Billie said earlier, perhaps, you know, we really need to think about how we can work harder to reach those sort of most difficult to reach members of the communities. And I don't quite have an answer for that just yet, but I think it's really important, again, to work with these community groups to build trust and relationships, especially in an organizational context where we want to continue to have those relationships over time and strengthen the work that we can do with them. And I think finally, for me as a researcher, I think you have to be willing to throw out your script when things just aren't going as you expect them to, take a different tack to your research, and take a different tack to even your interview or your session. And I think for me, that's a benefit of a qualitative approach. You know, I can come into the session thinking, oh, I definitely know what I need to ask. I know what the barriers are. I know what's going to happen. And, you know, your participants can really surprise you. I found this particularly in our African group. I realized about 5 minutes in that my focus group questions were pretty much useless because everyone was just going to tell me their life story and how they have interacted with cancer in some ways in their life. And I could get what I needed out of that by sort of asking some leading questions here and there. So I think maybe that's just a skill you gain doing interview and focus group kind of sessions over time. I think I'll leave it at that, and we can open everything up for questions. Thank you. Emma, over to you.
Thanks so much, Jess. That was really helpful and informative as well. And I particularly like the way that, you know, in this project, you've tried to distinguish between established and emerging communities. And I'll be interested to hear more about how that pans out over the course of the project. So we have actually run longer than I expected we would with the talks, and I realise not everybody's necessarily going to be able to hang around after the 90 minutes, but we can start the questions for panel discussion. If anybody has a question, would they like to use the reactions to raise their hand? I'll sort of direct to people, and you can unmute yourselves to ask the question. Okay, I don't see any reactions yet. Hopefully I'm not missing anybody. But perhaps if I start off by asking Billie, I wanted to actually ask you about issues with things like simplified consent forms and offering incentives and getting those sorts of, I guess, strategies past ethics committees, which I think in some instances can be easier than other instances. And I'm quite interested in the way that, you know, a gift or an incentive can sometimes with, you know, a priority population might be seen as coercive if they happen to be living with disadvantage, whereas if you provide an incentive to a GP who might otherwise be missing out on income to run an interview, that's not seen as coercive. Do you have any comments, I guess, or ideas on that?
Yeah. Lots and lots of conversations with ethics committees about these sorts of things. Yeah. I think for an ethics committee, you really need to justify what you're doing, and you need to think through those ethical implications and make sure that you've covered any ethical questions about what you're doing. It is in the NHMRC ethics guidelines that we can provide reimbursement for people's time, whether they're doctors or lay people from the community. So I think that nowadays it is easier to provide reimbursements than it used to be. I think that some thought needs to be given as to what it might be, because also some cultural groups are insulted by the provision of money, for example, and so non-financial reimbursement might work for you know, some target groups better than financial incentives. But yeah, just providing really strong justification. We usually, if we're using reimbursement to retain people in research, we'll refer to the literature, and I'll even cite that literature review and say, look, this is an evidence-based approach, and we're using a type of reimbursement that is acceptable to the community. We've spoken to them, and you know, whether or not it's coercive, it all comes down to reimbursing people for their time. Do not use the words financial incentive in your ethics application. It's reimbursement for participants' time.
Excellent. And now that you've provided us with your systematic review, we'll all be able to point to that evidence, which is great. Thank you. Jess, sorry, Kate. Yep.
Oh, I was just going to add about the information sheet. I think it's always good practice just to go over what's on an information sheet verbally with people, because you'd be amazed by the number of people who don't understand them, even if they are sort of written in simplified language. So I'd always, read just, and then make sure you give them time to ask questions too. I think it's important.
Excellent. Thank you.
I think that's a really important point. And for a couple of our studies where we had populations with low literacy levels, we actually the research assistant videoed herself talking the information statement. So rather than someone having to sit there and read 3 pages of a participant information statement, it's a 2-minute video of someone giving them the information.
That's fantastic. And I don't know that I've heard of that necessarily being done before. And I think that's a great approach. Jess, sorry, I just wanted to ask you, since you've been sort of working with various different culturally and linguistically diverse groups, what do you think has been the most rewarding aspect of doing research with these groups?
I guess I feel really grateful for the opportunity to step outside of, my own sort of day-to-day social world and being invited into somebody else's, into another group. On a personal level, like, people are so warm and welcoming. I'll get invited to, come attend a special dinner or something, which is amazing. I just find it very humbling to think from different perspectives and think about, how what I do can make some sort of impact.
Sure. And do any of you have a comment on what are the reasons that researchers may hesitate to conduct research with vulnerable or priority populations? We've obviously heard quite a lot about the challenges today. Did any of our speakers have an additional comment? Okay.
Well, I guess it's just fear of the unknown, isn't it? Like everything, if it's unfamiliar to you, it's it's more difficult. So I don't think it's really any more complicated than that. And the other thing, I guess, is it is expensive to do well. To travel to rural areas, and often organisations will insist, for example, that you have 2 people who go into people's homes, and it would be way easier just to interview city people, for example, but the extent to which you can have an impact on a vulnerable group will be more limited. So I definitely think it's worth the effort.
Thank you for that. I'm aware we've got people dialing out more and more because we're going over time. Do you each have another 5 minutes, or do you think we need to wrap up? Okay, sure. Do you think there are prevailing myths about conducting research with vulnerable populations? And if so, what do you think they are?
I think that one of the myths is that everyone's the same. So there's actually no need to put in this extra effort, because we've talked about how expensive it can be and time consuming and resource intensive. And so if you just do general population health and medical research, that covers it all, and you can generalize your results to everybody. But there's lots of examples of why that assumption is wrong. So I think that's a myth, and I think that when people start talking to and working with smaller population groups, it really opens your eyes to the differences.
Great. Sorry, Kate.
One that I come across a bit is I find that people assume because I'm doing rural health research, I'm doing Aboriginal health research. And, I really think that Aboriginal health needs to have its own own work done in it. We can't, just because people live in a rural area, the findings don't apply to necessarily to Aboriginal people. So that's something I find I'm often explaining. No, this is, you know, while we don't actively exclude Aboriginal people from our rural research, I don't think that we can extrapolate the findings to those communities.
Yes.
Okay. I would say for my work with culturally and linguistically diverse groups, there's often sort of an assumption that it's always language that's the problem, when it's oftentimes, you know, a whole host of other factors that may be cultural or structural. And oftentimes I even found in the literature a lot of mentioning of health literacy as a big barrier, which I don't necessarily think is wrong, but I think also kind of dismisses the knowledge that people have that may be different and not necessarily in a Western medical science paradigm, but nevertheless is still valuable knowledge. So I just think it's really important to not be dismissive of the kind of very valuable and astute perspectives that our populations already hold.
Yeah, great, thank you. I think that's a really important point. Just to finish up, I might ask one final question. In addition to what's already been discussed today, I guess just a rounding off question on how we can make sure that our research is worth it for participants who belong to a priority or vulnerable population.
Should I go first? Talk to them. Gosh, talk to them. Make sure that your research is addressing something that is a priority to them. And the only way that you will know that is if you talk to them and ensure that your research is community driven in that way.
Okay.
Another thing is, I think we have, if we take people's time and we collect this data, I think we have a responsibility to publish it, and to publish it in academic journals, but also to publish it in a way that that it can inform the community that we've gathered it from. So in, you know, readable documents, you know, one pages for them. And I've found that when you do that in an effective way, the people who've participated in your research can become your strongest advocates, and then they'll go around and they're very proud of their participation, and they can really help you implement the solutions. And it's, yeah, it can be a very empowering and rewarding experience for participants if it's done in the right way, I think.
Fantastic. Yes.
All right, I'll answer to round things off. I've only been at the Cancer Council for 2 years, but I just wanted to speak to, I guess, my experience working in an organization in that sense, in that I'm already sort of working with people with a sort of prevention or advocacy perspective on my team. So I guess that's sort of designed into our research from the beginning, that yes, we want to have publications and hopefully sort of impact in a broader way, but we're also really looking to improve the services that we're delivering from the beginning of the research. That actually the research came from them. This question came from that part of the organization to begin with. So yeah, I just think that's another perspective on a way that that we can have impact on the communities we're working with.
An important one. Thank you. Thank you all so much for your time today. Thank you very much, everybody, for dialing in. I've personally thoroughly enjoyed listening to all of your presentations, and I'm sure the other people who have dialed in today will find them really helpful as well. It's been great. Thanks.